some of the brightest young people in the country and perhaps in the world. And from what I understand from the emails that I got, you are at various stages of completion of your first degree in medicine from what has to be the premier medical school in the country. So initially when I was invited, I wasn't exactly sure what I was going to share with you, because I'm an economist, I'm not a medical person, and most of my work has to do with ideas that are somewhat broader at the economy and the system-wide level, not necessarily at the patient level. But I was given to understand that at least some of you may have an interest in some of these questions. So I thought, why not give it a try and see if there is a conversation we can begin. So let me give you a sense of what I do and my area of work, and then I'm hoping that we can have more of an interactive dialogue, because what I'm not able to assess, given how unusual this audience is, what is the exact interest areas that each one of you has. So as as was mentioned in my introduction, I'm trained as an economist. My PhD is from the University of Pennsylvania and the Wharton School in economics and finance. And before that, I have an MBA from AIIMS, also in finance. Most of my career, I've been a banker. My last engagement was with Reserve Bank of India. I was a board member of the Reserve Bank of India, the central board in Bombay. And I was also chairman of the Eastern Reserve Bank of India. But much of my working career I spent with the old public sector entity called ICICI, and then when it became the new bank, ICICI Bank, and I was, the deputy managing director, reporting to the CEO, Mr. Kamath, for many years in that bank. The last 7-8 years, I've gotten involved in understanding the challenges of healthcare in India. It is my view, and I'm eager to hear what you all think, as an outsider and now as somebody that's been working on it for about 7-8 years, that we are not doing very well on the healthcare front. In the League of Nations, and some of that work I do, looking at cross-country analysis and such like, our rank remains low, and even far poorer countries, our neighbors Sri Lanka, Nepal, and Bangladesh, African countries like Rwanda, Kenya, Tanzania, South Africa, and of course, our neighbors to the east, countries like Thailand and even Vietnam, are actually doing quite well relative to us. And more importantly, even those that are not doing so well, I believe are on their path in the next 10 years to making a lot of progress in their health systems. My belief is that we are not on such a path. If anything, my concern is we are on a path further and further away from building good health systems. And we risk ending up at the bottom of the pile, despite all our resources and despite all our talent, in a 10-15-year period. And I'm certainly happy to talk some more to you and to get your thoughts on some of these statements that I'm making. I thought maybe this is an area that I could spend some of my time engaging with. And that's what I've been doing for some time. Unlike all of you, however, I'm not at an age where I can begin new work or start enterprises or start hospitals or any such thing. So my role very much remains that of researcher, aspiring designer, and most of what I do is in collaboration with other organizations. Most recently, I was the India country director of the Gates Foundation, It's a large global foundation headquartered in Seattle. India is its largest office outside Seattle. I was with them for about almost 4 years. Again, very much part of that role was very much part of my journey to get more deeply involved in healthcare and health systems design. So that's what I do. Just to give you a little bit more of a sense of where I have had a specific role, I was a member of Dr. Srinath Reddy's high-level expert group on universal healthcare that was appointed by the government and submitted its reports in 2011. More recently, there was a task force of the government to design health and wellness centers. I was one of the members of that committee and one of the authors of that guideline. Very recently, I headed a task force for government of Chhattisgarh for the design of the Chhattisgarh state-run health system. And I had a similar role along with Dr. Vinod Paul, somebody that I'm sure you all know very well, Dr. Guleria, Dr. Bhan, in the Himachal Pradesh Health Commission. Unfortunately, despite all of these roles and despite all of these engagements, it is my belief that we have not made much progress and that fresh work, fresh thinking is needed. I'm a commissioner on the Lancet Commission for Reimagining Healthcare in India. I chair the finance work stream and I collaborate closely with the technology work stream. The hope is that through such efforts, we will be able to at least put some ideas out. Certainly I'm happy to share some of those with you. But I believe we are on a long journey. It is going to take us a significant reimagination in order for us to make progress. We have thus far, over the last 60 or 70 years, failed in our attempt to persuade state governments and central government to take a sufficient degree of interest in healthcare. The contribution that our governments make in healthcare remains one of the lowest in the world as a proportion to our GDP and a proportion to our budget. And unfortunately, they are spending in the neighborhood of 0.7 to 0.8% of their GDP, of their GSDP on healthcare. It's actually the reason why the national average is much higher at 1.35% is because it's the poorer states like UP, Bihar, which are larger, which are spending, close to 1.4, 1.5%, but well below any number that would be considered respectable from a global perspective, and that would be necessary to deliver basics of healthcare across the country. So indeed, we are going to have trouble if we depend entirely on the government to deliver the services that are needed or even to finance them. Unfortunately, as soon as we say that, we kind of come into a no man's land. Because if you read the global literature, if you go and be a student at Johns Hopkins or at Harvard University or join the World Bank or the WHO, they haven't really thought about this problem. They assume that the government will come up with the money and all of their ideas and solutions start from there. But in an environment like ours, and sadly in most developing countries, so I'm curious why many of these institutions haven't paid attention to this reality. Nigeria is the other country that I'm somewhat aware of because Gates Foundation has a large office. It's our second largest office after India. And again, they are in fact somewhat of a worse bucket than we are, even though from per capita income perspective, they are richer than us. From an healthcare perspective, they are where we are. So I do have some ideas that I'm working on. And if there is interest, I'm certainly happy to debate them with you, discuss them with you, and to see what you think. Might be your people engaged day to day in healthcare. Whenever I have had opportunity to visit with Dr. Paul in his residence in the AIIMS campus, I encounter a sea of humanity. And I must say, I have deep respect for all of you that work there, that study there, because the service you provide is exceptional in an environment that I am sure can be quite challenging. So I will stop here for a minute just to get a sense of, what do you think about this? Are there other questions that you have in your mind? And happy to go deeper anywhere you think would be helpful.
So I had a question. Since you mentioned the Nigeria office of the Gates Foundation, one thing that we, frequently read is a paradigm related to the fact, and it's actually a criticism of the Gates Foundation, how it, puts its money towards specific diseases like, let's say, AIDS or malaria, and thereby diverts attention from, core issues that might be affecting children, like the infant mortality or stuff like that. And, it drives primary care physicians towards those more specialized fields. So in the position in which you are, from where you see it, how do you, see a balance happening in that scenario?
I mean, I cannot speak for the Gates Foundation right now. I'm no longer with them. But what I can say is that at least on these two fronts, the criticism is not well founded. Yes, it is true that the foundation has had a big focus historically on vaccines, but a lot of it has come because of, it's a family foundation, you have to remember. It is, while it is much larger, it's driven by two individuals who are very much like me and my wife. So we give money where we think our passions are and what we think. So a lot of their work has been driven by the fact that they are parents themselves. And when they started the foundation, they had very young children. In fact, their eldest daughter has just gotten married. So even now, their children are very young. So their entire motivation to get into this was to improve the lives of children around them. Why did they, for example, commit to eradicating polio from the world? They are by far the largest funder of polio, including governments, including foundations, because children were getting impacted on this. Why have they invested in the development of vaccines? Because children were getting impacted. And in fact, in the work that we do in India, the commitment is to government-owned, government-delivered care with a specific focus on states of Bihar and UP. And almost the entire engagement is towards reducing infant mortality, maternal mortality, nutrition, working with the government. If there is a concern, one might argue it might be that non-government actors, private actors, or others that may wish to play a role, the Gates Foundation does not work with them. It works almost exclusively with government, and even when it works with a non-profit, almost all cases, not all cases, but almost all cases, it works only with those non-profits that work with the government.
Right, sir. Makes sense.
I had one question. So I would really like to know what you think the problem with our healthcare system is. And I'm really interested to know how, from a perspective of an economist, do you plan to solve that, or what solutions you have in your mind? Because if just giving money was the answer, then I think we would probably have solved it by now. So what do you think the problems with our healthcare system are, and how do you solve them?
Thank you, Dr. Patel. I think that is an important question, and indeed a question that I have been spending most of my time trying to at least understand the question, if not have good answers to. My understanding is, and this is why I believe that any solution that we develop will have to be developed locally. I don't think we can depend on the international agencies, international institutes, WHO, etc., to tell us how to figure this out. In fact, as I mentioned to you earlier, a lot of my work has been in finance and in financial access. I chaired the Reserve Bank of India committee on access to finance in 2013. And a lot of the programs that you've seen since then come out of the government, come out of the Reserve Bank, they were not necessarily my ideas, but they were ideas that came out of the committee. And you will see many aspects of that committee are not so relevant to healthcare. But one aspect is indeed relevant, that the ideas are all our own ideas. They are founded in our reality. They reference ideas from elsewhere in the world, but not necessarily cut, copy, paste those ideas, or are driven by a vision that the WHO or the World Bank has set. It's a vision that we set, it's a solution that we arrived at. And over the last 25, 30 years, I would say in financial services end, we have made tremendous progress. All of you use payment services. For those of you that have had an experience of living elsewhere in the world, you will get a sense that on some dimensions, not all, some dimensions, we are able to offer services that no other country is able to match, even to the very poorest individuals in our country. I'm sure you have gone and bought vegetables and fruits from vendors who want money in Google Pay, right? You don't see this elsewhere in the world. And I think we have to take inspiration from that and draw confidence from that, that if we as a country and we as a people say, we are going to figure this out, this is our country, this is our problem, we will of course learn from everybody. I wouldn't say that we should, ignore that experience. And there are fortunately somewhere near 80 countries from whom we can learn. But what we do on the ground will have to be our own. So that's kind of one important issue. The second important issue is any solution we develop will have to be multi-pronged. It cannot say government will do it. It cannot say, we will find some scheme, or that, non-profits will figure it out, or the private hospitals are the answer, or that Gates Foundation is going to provide the money. We are going to have to look at least 6 or 7 different approaches to bring together. Let me give you some examples of questions that I'm working on, and maybe share with you some ideas that specifically interest me, and I'd be keen to hear what you think. Let's talk about provision. Okay? One of the questions that we are debating is, how do we actually bring services to the last mile, right? And the last mile could be a slum in Delhi. It could be a village in UP. It could be, I don't know if that is your experience, but it's my instinct. I have never actually interviewed patients at AIIMS, but I have had some exposure to patients at JIPMER, for example. Many, I would not say, 100%, but somewhere near 75 to 80% of the patients that are, milling about in the AIIMS compound are perhaps in the wrong place. They came here because where they come from, they were not able to access even basic services. And that, they found themselves here partly because of much delayed care or simple lack of knowledge as to where to go. AIIMS is the place you end up, so they ended up there. Right? So, and I'd be keen to hear whether the data supports my initial hypothesis or not, but that's certainly my presumption. So the question is, how do we solve this? And what do we go about? So let's take the issue of rural primary care. I had the good fortune of being closely involved in a co-founder, co-developer capacity with a research-based effort out of Tamil Nadu, in Tanjavur, which tried to roll out primary care in about, population about 200,000 people, 2 lakh people, through about 20 clinics, comprehensive primary care, to see what that felt like, to see what the barriers were. Because a lot of people were telling us that this is hard to do, and that it would be very difficult to make it work. Now, some of the challenges that we felt were preventing this issue from happening was that there was an excessive reliance, and I think India now is starting to be one of the few exceptions in this, on a what one would call a gestalt-based approach towards diagnosis and treatment, as opposed to a protocol-based approach, as opposed to being guided by the best understanding that is available most recently. And you would have all been involved one way or the other. Even as a non-medical person, I was involved for a variety of good and bad reasons with the whole COVID-19 ivermectin controversy. And you get a sense, certainly as an outsider, I got a sense of how little evidence-based mattered and how we were going ahead. I used to be shown prescriptions by doctors, by patients. Only thing missing in that prescription was the kitchen sink. Everything else was there, from antibiotics to antihistamines to ivermectin to steroids, all in one prescription, because the doctor had no idea what they were doing. Perhaps rightly so, because initially we didn't even know what the disease was properly, and were throwing everything at it. To give you a kind of a more global example, right? The best trained doctors, GPs in the world, family care doctors, are in the UK, right? The general practitioner in the UK is considered to be, an MD in family medicine, really highly trained, highly qualified. The evidence is, and for those of you that are, interested, I'm happy to send you the reference, that when it comes to cancer, for example, rare, unusual disease, understanding of how to diagnose and treat changing rapidly as we go deeper and deeper into genetics and other, aspects. The GP is under-referring to the extent of 60 to 70%, which is starting to indicate that this old idea of training-based black box, you take a highly trained doctor, put them in a place, and they then somehow magically figure out, what the right answer is, may not be the best way forward, particularly in primary care settings. And then, of course, in remote areas, you have the added problem that, despite all the attempts to force doctors to work in those areas, you're not getting a lot of traction. Question is, okay, this is a problem, so what is the way forward? The way forward, and I'm inspired in this work by what the Alaskans did. Alaska, as you know, it's a very large territory. It has a number of villages and on sheet ice, but each village has household strength of maybe 200, 300 households. And each village is separated from the next village by over 1,000 miles. Right. So it's a very, I don't know how many of you have been trekking in the Kalpa-Baspa Valley. It has that flavor of it, but it's, it's not as hilly, but otherwise it has that flavor of remoteness. They have been able to provide universal care, primary care to their population. So the last 40 years, what is the approach they have taken? They have not gone with this doctor centricity that seems to be a defining feature of what we want to do. What they have done instead is brought local young men and women, asked communities to nominate these people, and then trained and supported these people to provide a full range of primary care. Mental health, diabetes, dyslipidemia, full cardiac work, everything. And they've done it well before.
Interrupt you here, but isn't this something similar to what ASHA workers or Anganwadi workers have been doing at a community level?
The ASHA worker, I don't know if you've actually dealt with an ASHA worker. I would say not at all. The ASHA worker mostly refers, has very little curative competence, is not legally permitted to prescribe. There is some relaxation now for the ANM to give amoxicillin drops, but that's it. I'm talking about comprehensive primary care, comparable to what a UK GP is doing. Now, if you take that one step further, you combine that with technology, and I want to take a few minutes to show you two things. That one, something that is not something I'm working on, but something else that I'm working on, which kind of brings the two together. To give you a sense of how different in look and feel, that is, in fact, so different that you might, worry that is perhaps too much at the edge. So just give me 1 minute. Let me just figure out how can I share this stuff? I've never used this platform before. Is there a way I can show you what I have?
Yes, I have made you the presenter. I think you can share.
What should I do? I should just put it on my screen, or what should I do?
Right,
There's some
right,
button
yeah.
called share screen. Should I just use that?
Yep, yes.
Okay, let me do that then. So let me just pull it up. It wants me to pull it up first.
Here you are.
So what I'm going to begin by showing you is some work I'm doing with Artpark. This is the Artificial Intelligence and Robotics Technology Park and Institute of Science in Bangalore, in which we are trying, and this is going to be a part of the work I'm doing for the Lancet, to imagine what primary care might look like in the future. Okay, so let me show you that. It's a comic strip, so that it's easy to get a sense of what is being spoken of, and then I'd be keen to hear what you all think of it. Right, and then that will take you to the next one. Are you able to see my screen?
Yes, yes.
So this is, we set it in, this is all work done by Artpark. My role was more, authoring the idea and thinking through the concept. But really the beautiful graphics and, all of this work was done by the Artpark team. And Raghu is the president, the three authors that are there, myself, Raghu Dharmaraju, and Amishi Parikh. Amishi was the person that really communicated to the illustrator and developed many of these specific visuals. Raghu and I collaborated on developing the overall idea. So, the notion here is to give it the UK GP feel. Here is a GP clinic. Here is the patient family. We had originally imagined that we might meet them at home, but, the illustrator felt that we don't have enough. It'll add too many frames. So we brought them to the clinic. The general understanding from the UK GP world, there are good papers from the 60s, is that patients normally don't show up for preventive screenings. You have to do preventive work while they have come for acute work. And that's really the context. But again, this kind of detail we thought we'll take forward later. Ashia is the health aide. She's not a MBBS or MD doctor, but she's the principal primary care provider and responsible for the clinic. Typically, you will have a team. Again, limits of illustration, we couldn't show you the team. But right now, let's imagine Ashia is the person and she's invited Mr. and Mrs. Krishnan to her facility to do this. She's supposed to be responsible for about 1,000 households, comprehensive primary care, not just maternal and child health or all of that, full primary care. She's trained to use a number of pieces of equipment. We have shown you, you're all doctors, so you know what this is. A number of issues. Some of them are easy and obvious and visible. There's no trouble. There's some legal issues around the use, for example, of a transducer. And what are we going to do with the point of care ultrasound? There are legal issues. The tech is still not stable. We will show you what we have in mind with that. We have, as you can see in this screen, we have a thermal camera, which is to preliminary diagnosis of cancer. It exploits some aspects of cancer. And there's a company in Bangalore called Niramai that has just received US FDA approval for the work that they have done with breast cancer. And I think with some diseases, infectious diseases where worms are involved in Africa. And you can see the way the examination table is. It can be used for multi-purpose. This actually borrowed a little bit from the work I was involved with in primary care in Tanjavur, where there are stirrups for cervical exams, cervical cancer exams, but also, you can convert this bed into a dental chair if you need it to. So she's being guided now by a strict set of protocols. For some other work that I've done, what I did was I combined 4 sources of protocols to develop a comprehensive set of primary care protocols. One is from the NICE of UK, the other is the US Preventive Services Task Force of the US, HITAP of Thailand, and the Gates Foundation, WHO, World Bank. We collaborate every 10 years to bring out something called disease control priorities for developing countries, which is kind of the equivalent of NICE for developing countries, and it's not updated so regularly, updated every 10 years. If you're interested, I'm happy to send you the link to it. It is 9 volumes now. When the first version came out with just one slim book, now it is a very detailed. Drawing from that, I've been able to, extract protocols that make sense for primary care settings. Right now, we are just focused narrowly on cardiovascular disease. You're all experts here, so I'm not going to say too much for the fear of embarrassing myself. But you can see the body mass index, you can see blood pressure. The protocol authorizes her to start amlodipine 5 milligrams. Remember, this is 2030. There are legal issues, etc., which we need to sort out. Just give me 1 minute, please. Just 1 minute. Sorry. So, this is what she's doing. What I want to show you a little bit is the technology, as I said, is not quite as stable as we would like, but it's there, is what she does with the ultrasound. Right? So she has a transducer with her. It's connected to her pad. I think GE has a Lumina platform that allows this to happen. But now she has an augmented reality, an AI-assisted point-of-care ultrasound. She does not see the image directly. What she's told by the machine is the exact path she should follow with the transducer. The machine is adaptive, so it changes the path as it learns more. And she has to stick to it, otherwise it warns her to come back to the path. Anyway, so that's what she has done. You get a sense from her, from the machine tells her that this gentleman is at high risk he has cardiovascular disease. He is at in a high risk category, he needs both to take more action as well as to be examined further. So there's some discussion on mental health, etc. I'm happy to send you the link if you want to see more. I want to go to what she does with the woman, in which now she's using the thermal scan. Right? When she says here, according to the scan, there is a small lump on the left breast, that comes from the thermal scan. That tells her, again, using machine learning and AI, what is happening there. She uses the point-of-care ultrasound to understand, is there vascularity in that lump, and might it be cancerous. Now the protocol tells her that you reach the limit of what you can do. You will now need to talk to an oncologist. This is what she says with the patient. So this is then a conversation between her and the oncologist. Remember, this is not regular telemedicine in which the patient is directly calling specialists on demand to figure out what's going on. So they're having a conversation. She shares with the specialist what her concerns are, and then the specialist gives her some guidance, both for referral of the patient as well as says that we need to modify the protocol a little bit. So my sense is that this vision of primary care, it's very far away from what the ASHA is doing. Just to give you some data on the ASHA, the requirement of is, for example, for 4 key aspects of antenatal care, that needs to be given by the ASHA to pregnant women. 2015-16 data shows us that if you ask the question, how many pregnant women in, for example, the state of Bihar received this service, where the coverage of ASHAs is 100%, only 3.5% women received these 4 services. There is nowhere near this kind of equipment that she has access to at her sub-center, and I would imagine even the medical officer in charge of the local PHC might struggle with many aspects of this diagnosis and of this work. The training of the aide is what I would call horizontal. She is not an expert in any one area of work. She is well trained to deal with patients, to deal with cultural issues. She has time with her. She's able to visit homes and ensure compliance with medicines. And she's trained to use a lot of equipment, which is relatively simple to use. We're not asking her to interpret ultrasound images, but there are many things that she can do that can help the protocols be driven, as well as when there is a referral or a more advanced conversation to happen. These models are now getting implemented worldwide. Some places with the help of doctors, some places with the help of nurses. And as I mentioned to you, in places like Alaska, Costa Rica, you're doing this with health aides of the type that I've described here. So I can pause here, but there's one more thing I want to show you. And then I'm keen to hear what you all think, because it's part of what I'm trying to build as a vision that I'm keen to get your feedback on as to, is this even feasible? Does this work? Is this an idea worth considering? Or there's something so fundamentally wrong with it that we should not even pursue it. Right? So let me show you another piece of work, which is not mine for sure, but you know, hopefully it'll give you a sense of what's going on. I hope you can hear sound here. Are you able to see this YouTube video?
Yes, sir.
Yes, I'm going to play it. Just let me know if you're able to hear sound. Is the sound coming through?
Yes, sir.
So this is a program called Babylon. This is something that you know, Gates Foundation used for the first time in Rwanda. Now it drives a UK-based healthcare service called GP at Hand to provide primary care services like a GP, but to a much larger number of patients. What I'd like you to do is to look at all aspects of the screen. There are auto transcripts. There's something going on with her face. You'll see differential diagnoses going on, and what the machine is doing and what the doctor is doing, just to see.
Nice to meet you.
Hi, nice to meet you too.
So I can see you've completed our AI assessment. And from this, can I confirm that you've been having dizziness for a few months now with some hearing loss and also some ringing in your ears?
Yeah, that's right.
Okay. You look quite comfortable at the moment. So does the dizziness come and go?
Yeah, I don't have it at the moment.
Okay. And when you do get the dizziness, how long do the symptoms last?
A few hours at a time, I'd say. Yeah.
Okay. And does changing the position of your head bring on the dizziness? Sorry, what I mean to say is, do you get dizzy, for example, when you turn your head to look to one side or when you turn over in bed?
Oh, okay. No.
Have you felt sick or vomited when you get the dizziness?
No.
And is there anything else you wanted to tell me about your symptoms? For example, have you had any headache, any weakness, any numbness at all?
No.
According to our records, you also had glandular fever a few months ago. Has that all settled?
Yeah, that was awful. It's gone now.
Great. I mean, just looking at the blood test results from back then, they all came back normal as well.
Great.
So I would agree with our AI assessment. It looks like your symptoms are being caused by a new condition called Meniere's disease. This is causing a buildup of pressure within the balance center, and that's what causes those awful dizzy episodes that you've been getting.
Okay.
The most important thing now is to relieve those awful symptoms. So I'd like to prescribe something called prochlorperazine. Can I just double check you're not pregnant at all?
No, no chance of that.
And you're not allergic to any medications?
No.
Okay. So I'll send that prescription to your usual pharmacy. It'll take around an hour or so.
Okay.
Does that all sound okay?
Sounds a little bit serious.
Well, as you found out, the symptoms can be really serious when you have them. But Meniere's itself usually isn't, and it can be really well managed with medication.
Okay, thanks.
One thing to mention, given that it looks like you do have Meniere's disease, this could put you at a high risk of getting migraines. So I'd like you to do our migraine risk assessment, and that way we can see if there's anything that we can help you to reduce your risk.
Okay, yeah, I'll definitely do that.
Great. Okay, so I'll just run through the next steps to confirm your diagnosis and how to take the medication safely.
So this is a service called Babylon that we used as Gates Foundation in Rwanda. Rwanda, as you know, stopped constructions of all hospitals until 100% of the country was able to access primary care. Today, they have 98% coverage of primary care, even in the remotest of villages. And a model very similar to the comic strip that I showed you, combined with Babylon, is being deployed in Rwanda. Of course, you know, some of the technologies I mentioned to you are still not there yet. There's work to be done over the next 10 years. But just to give you one sense, you know, there are many aspects of health systems that we could talk about. But, you know, talking about provision, this could be a direction. The benefits here are we have an infinite supply of such people. They need to be well paid, not like ASHA workers, you know, being given piece rate, some small amounts of money. But they can provide a range of services that we can universalize relatively quickly across the country. So I'll stop here. I'm keen to hear what you all think, whether, you know, you think this is all rubbish, or is there some hope you see for us, or if you have other ideas.
I think this was really eye-opening. I mean, you have given us all existential crisis, I guess. So the thing that I wanted to ask was, I mean, when the new NMC bill came, there was also a lot of opposition from doctors regarding allowing people from other areas to practice certain aspects of medicine, to allow them to prescribe some medicine. So one thing that I've always wondered is, don't you think if we incentivize doctors better to work at grassroots levels, won't they go to those areas and serve over there instead of training other people? I mean, what you showed is something that we learn in MBBS, and last 3 months I have spent as a primary care doctor in villages in Haryana, and this is what I have been doing, right? So during MBBS, we are more or less basically trained to do what you showed us, and so if we just incentivize MBBS doctors better, won't they be better equipped to do all of this instead of, you know, training a whole new workforce?
The question you have to ask is, and you would know better than me, the evidence seems to be that this is not happening. It's not just in India, it's not happening in the US. If you see rural Nevada, Alaska, why are they doing this in Alaska? Doctors are refusing to go. They are well trained. The country has a shortage of specialists. We have restricted the number of PG seats, but why have we done that? Not entirely clear to me. We have, I'm told, fewer than 5,000 psychiatrists in the country. So really, there is a big need up there. Is that a good use of our resource? Somebody who has spent years developing a more general capability in surgery, in medicine, to be doing something that a much more narrowly trained person following strict protocols can do. The government has schemes, has attempted many times to force doctors through bonds, etc. You have not seen them work, as I said, not just in India, elsewhere in the world. And we need a number, you know, if you look at the size of the country, of somewhere near 2 million such people. compare that with 30, 40, 60, 50,000 doctors that we are producing every year. And remember, the world is aging. There's going to be a massive demand for trained personnel, medical personnel from the world. Cuba is one of the largest exporters of doctors. Why can we not be? So I would say, rather than ask the question, now you're talking about legality. Clearly there are concerns, but again right? Telemedicine guidelines, for example, allow us to have a doctor prescribe remotely. What prevents them from saying, I have 100 nurses working with me, 100 community health aides working with me, and they are doing the initial consultations, I'm doing the final confirmation. Even in emergency room settings, I understand standing orders, which are nothing but protocols, are the norm. The law can be changed. There's also, while the NMC bill has Act has taken a certain position, if you read the Supreme Court judgment 1998, Mukhtiar Chand versus the state of Punjab, you will see that there are some sets of providers, not necessarily the full range, that actually don't need approval from the Medical Council or the NMC. They need approval from the state government. And 8 state governments have given them approval to directly prescribe. So, I mean, right now, I'm not as concerned about the legal issues, because I'm assuming, as we build them out, we will get more traction, but more from an, does it make sense from a quality and availability perspective?
So could you repeat which case you referenced to?
8 states have done it. Let me give you the names of a few that I remember. Maharashtra, for example, Tamil Nadu, for example, everybody's taken a slightly different view of what they do or what they do not. But in fact, frankly, I would say you should read the judgment, Supreme Court judgment. It's in 1998, Mukhtiar Chand was the state of Punjab. You Google it, you'll get it.
Good afternoon, sir. I'm Amulya Gupta, final year student. So I visited the village, the primary healthcare centers, and I had a brief experience over there. And what I found was, that's what I felt, that doctors there are operating with clipped wings, essentially, because they are not given enough diagnostic tests to reasonably practice medicine. And we also do not have enough medicines to prescribe as an armamentarium over there. So what I felt there was that we probably do not need a person who is trained 5.5 years in medicine to practice in those primary healthcare setups, and we can actually have someone who's trained for 3 or 4 years at maximum. So what are your views regarding this?
I would say, underneath though, your question is that it's still the idea that you have a black box of training and certification that is producing this, right? I believe that the right approach is much more, training as needed, training that is just in time, much more horizontal training rather than vertical training, disease by disease by disease. Primary care, while it seems simple, the reality of primary care, as you would acknowledge, is that I don't have a diagnosis. I have symptoms. And I have to make the judgment whether I send this person home and say, Kuch nahi hai, you've eaten some bhel, go home. Or do I say, you have, advanced colon cancer, sir, I need to admit you immediately for a surgery, right? That's a decision a primary care doctor will have to take for bulk of the population, right? Which means you need somebody who can handle a vast range of diseases. I don't think a disease-specific training will work. That's why the partnership with technology, partnership with protocols, if you see in that particular, strip, the ASHA, the health aid, is directly now being referred to an oncologist. She didn't go to another GP or to a medical officer. Because what would the medical officer know that the computer didn't already tell her? She now needs judgment of a much more advanced level, which a medical officer will not be able to provide. Now, you're quite right that what about medicines there? What about diagnostics tests? Which is where the whole awkwardness is. The government is spending too little money on healthcare. But that's not true of the people of the country. The people of the country are spending a vast amount on healthcare, spending it badly, but they are spending a lot of money. Right? the principal primary care providers in India are not PHCs. They are anyway, really at a situated level where you should have a secondary hospital. What the government calls a sub-center is what I'm referring to as a clinic. Most of the places you would have seen, they are just shut. But even if they are open, that's not where most of the patients go. Most of the patients go to the local pharmacy. In urban areas, rural areas, pharmacy and pharmaceutical expense is an important, component of overall health spend. Right? Many countries have said, why don't we enable the pharmacist himself or herself to become a partner in chronic disease management, for example. Brazil, allows diabetes management to be offered through the pharmacist. So it's, exactly what the right channel design would be would vary state by state, would vary region by region within a state. Odisha, Kalahandi would need a very different approach from Bhubaneswar, for example, or even a rural area in the south of Odisha. But conceptually, the notion is, at least what I'm thinking about, is not quite bring one more black box with less training, but much more as needed. If you see the Alaskan model that I mentioned to you, they offer training over a 10-year period in blocks of 4 weeks. And there are, I think, 2 or 3 initial 4-week blocks, and then they stretch them out. Thailand started where we were. They didn't have enough doctors. They didn't even have enough nurses. They started exactly with the ASHA type that Dr. Patel mentioned, and then started to train and upgrade their skill sets, combining their field work and field capability with technical and classroom training, to the point where I understand today, many of their nurses have ASHAs have gone on to either become doctors or have become oncology nurses, or do a variety of other tasks. I'm not therefore saying we can't do it, but then that's the vision we will have to have.
Thank you so much for your perspective, sir.
Yes, yes. That's a good question. Very, very good question. And oftentimes, me and Mr. Bill Gates would go and meet the finance minister when he was here. And this was exactly the question that we would be given back, to say, tax to GDP ratio of India is 15%. India has many needs. This is all it can spend on health. When we collect more taxes, we will be able to do more for health. I would submit to you almost the opposite picture. Thailand has the same tax to GDP ratio as us. We spend 5% of our budget on healthcare. They spend 15% of the budget on healthcare. Where does most of the government money go, particularly at the state level, but also at the center? They spend a lot of their money, in fact, most of their money, interfering in markets where the government doesn't have a role. Why, for example, is the government continuing to fund government-owned banks, government-owned insurance companies, government-owned oil companies, government-owned railways, so many disciplines? I just read recently, BSNL is going to get another 50,000 crores out of the government. There was a strong logic for this in the 1950s because there was no private enterprise. Today, there is no such logic for the government to interfere. In fact, I would submit to you, interfering in markets, hurts growth. If they withdrew, growth would go up. One might say, okay, well, what about infrastructure? Rural roads, should they not be building rural roads? Well, I'm not saying they should not build rural roads, but the question is, how much do we build? India already is second only to France in rural road density per square kilometer. We are well ahead of China. China has only focused on national highways and fancy airports. They have not built the rural road network that we have. Thanks to Prime Minister Bajpayee, the Bajpayee Gram Sadak Yojana, you saw a lot of development on the rural roads front. Do we need even more roads to be built, rural roads to be built? I would submit to you, perhaps in some pockets, yes, but by and large, no. So indeed, it's a, and okay, that's one thing. The second question is, forget the central government, look at state governments. Why is a state like Kerala spending 0.7% of its GDP on healthcare? It has reduced its contribution to healthcare, right? As a result, not surprisingly, it's losing market share. Right? Early in 2015-16, about 40% of babies were delivered by the public sector in Kerala. 2019-20, 30% of babies being delivered by the government of Kerala. Why is that? Right? So clearly, underfunding by the government is more a matter, I believe, of the government, particularly the bureaucracy and the politicians, but I would say much more the bureaucracy, wanting to continue to remain in active business and operations and having trouble moving to governance as an approach towards this. Right? I have written a number of times op-eds and such like. If you go to my LinkedIn profile or Twitter, wherever, whichever platform you follow, this is not something I'm saying for the first time. I think state governments and central governments are actively hurting economic growth with their current investment policies. And of course, one of the reasons they are hurting economic growth is not focusing on human capital. We have this mental model that most of our politicians and bureaucrats grew up with, where capital is short, people are plenty. So they don't worry about people, right? Development of human capital, development of health, education, nutrition is not the priority because the mental model is we are short of capital. Unfortunate reality, or fortunate reality, depending on how you look at it, is that capital is not scarce in India. I was a banker for 25 years. There is no project that anybody could dream of that even a single institution like the ICICI could not fund today. Capital markets are deep. We have big business houses, Tatas, Birlas, Adanis, Ambanis, that can fund, you name them. They're funding nuclear power plants elsewhere in the world. They're building airports elsewhere in the world. So my own instinct is that there is the logic, the argument that the government doesn't have enough money just does not hold water.
Good evening, sir.
Yes,
do you think that privatization might be an answer? Because I believe that there are two extremes of healthcare systems. Like we have the US, where it's quite different from, let's say, the NHS, or where more public systems are dominant. So I want to ask you, where do you think India is heading, and what do you think would be a better system? Like, should we be like the US, or should we be more of government oriented, say like the NHS or UK? Yes.
See, the reality is that India is, first of all, not one single health system. Think of each state as fundamentally different. I remember meeting Mr. P.D. Rai. He's the MP from Sikkim, and telling him about some of our ideas on maternal and child health. He told me, Mr. Mor, that problem is no longer a problem for us. We are worried about addiction, we are worried about drugs, we are worried about suicide. Now, this is a problem of a health system that is comparable to what you might see in California, not in a developing country. Whereas a state like Bihar is somewhere below where Bangladesh is in terms of its ability to deliver even basic care. So, we have to answer this question, I would say, much more in the context of which system are we talking about. Globally, if you see, people have built very high quality government delivered systems, and people have built very high quality private sector delivered systems. If you see Japan, for example, right, it's entirely private sector driven. There's virtually no public sector service. Yet they have very high quality health systems. They have very good health, but that could be for a number of other genetic reasons as well. But they have very good healthcare systems as well. Switzerland, again, it's an expensive health system relative to other people in the world, but a good health system. UK, you mentioned the NHS. All of primary care is private sector, all of it. And roughly 60-70% of hospital sector is public sector and the balance is private sector. But it's all funded by the government. It is not funded out of pocket. So I would say, to me, who funds healthcare is more important. Who provides healthcare, I think each state will have to answer based on its own understanding of what is best for itself. I was, for example, as I mentioned to you in my introduction, a chair of a task force appointed by government of Chhattisgarh on looking at what the government should focus on. My argument to them, and I don't know if they will buy it, but since they asked me, was that right now focus on ensuring universal coverage of secondary care. If I look at districts in Chhattisgarh, while C-section rates have crossed 70, 80, 90% in the south, and in many districts, the government hospitals are doing more C-sections than the private hospitals. In the north, particularly in states like Chhattisgarh, UP, Bihar, these rates are abysmally low. As low as 0.2%, 1%. And I'm sure all of you are experienced doctors. I'm not, but even I, with my ignorance and limited understanding, guided by my colleagues, was able to see the consequence in terms of infant deaths and maternal deaths at such low rates of C-sections. My request to them was first finish that agenda. And one of the questions that they asked me was, well, doctors don't work in rural areas, not even in government hospitals. Well, I said to them, why don't we turn to Dr. P.V. Ramesh of Andhra Pradesh? He's a unique IS officer. He was, I think he's a CMC Vellore product, so not from your August institution, but he was health secretary, then finance secretary of the combined Andhra Pradesh. What he told me was quite interesting. What he said was that, people say access and quality as two words. In his mind, if there is no quality, there is no access, right? What's the point of saying I've given access, but there's no quality? It means you have not given access, right? So he said, I first focused on ensuring that I could provide quality wherever I set up government infrastructure. If that meant I couldn't put a hospital in every district, I put in every 3 districts. As I built capacity, I made sure there was good hospital infrastructure everywhere, including rural areas. And he said, what I found is that if I provided this good infrastructure, doctors were happy to go because they had schooling, they had housing, they had this, that, and the other, and they were happy to go. So Andhra, in fact, has the reverse problem, as you know. They have excessive C-sections, even in rural areas. Why is that? Well, for a number of reasons. But one of the reasons is they have surgeons, anesthetists, in every place. Because, you know this better than I do. You can't, it's a major operation. You can't do this without all of that capacity being there. So, as I said, state by state, the answer would vary, but I would say the government has 2-3 roles. One is ensuring access, quality access, completing the public health agenda. And sometimes we mix up public sector delivered private healthcare, such as delivery of babies, and public health, which is vaccinations, disease surveillance, health education, and such like, right? Clean water. That work the government has to complete. And I'm happy to say that this new act that is under debate, has some of the ingredients of taking the Tamil Nadu model, which, was a model in which the public health cadre was separated out from the curative cadre, and independent budgets, independent personnel were allocated to them. Now, if that becomes a national policy, that would be delightful, because that is another thing that government will have to both finance and provide. The rest of it depends on the state, is what I would say to you. Yes, yes. See, one thing we have to remember is no development process and no growth process can happen without failure. We keep, hearing in the press about, I don't know if you've heard the word unicorn, companies that have market capitalization of more than 8,000 crores now, or $1 billion. But for every unicorn, there are at least 100 failed enterprises. Banks are unique in some ways, but zero bank failure, I would say, is not a desirable situation, which means you're taking so little risk, you're doing so little service that you have built yourself for zero failure. That said, there are a number of issues that we can learn from each failure as we move forward. And clearly, as you point out, each time there is a failure, there is a loss, not of money necessarily. Like money, and this may be a little bit economists speak for you that you might or might not fully, agree with. Money is somewhat of an artifact, right? Particularly as the government issues it, because in some ways, let me put it this way, in order to repay the debt that it has, it can keep printing more and more money, right? The question that we have to ask is a deeper question, that are we going to get the growth benefits of this money? Or are we going to end up in a situation where we're going to be spending the money, we're going to be having the inflation, but we will not have growth, right? That is the worrying aspect, growth. And what some of the research shows is that if you don't allow banks to fail, and if you continue to support banks that are doing badly, what ends up happening is that they continue to make bad decisions about lending to people, and growth suffers. Now, so I would almost have the reverse question for you. Are we seeing enough banks fail? Are the banks that are surviving good banks, or are they simply banks that have not been allowed to fail? And are we paying the price as a country for that? And I would say the answer is very much the latter. And we need to allow, creative destruction, as they call it, to happen of enterprises, banks, non-bank finance companies, so that something new and fresh can replace these old, poor performing institutions. Now, immediately there is, first we have to catch up with all the growth that we have lost in the past. So India, I think the problem is not going to be stagflation. The problem will be more, and which is again comes back to the question point I made earlier. Unless we grow in real terms, and again I'm happy to get into debate of real and nominal, in real terms at 12-13% per annum. Even by 2050, we will remain amongst the poorest countries in the world on a per capita basis. Right? Imagine we are only in 2022 right now. Right? China did this for 3 decades. This is how they have now become, on a per capita basis, a far richer country than we are. Right? So our bigger problem is not that we will not get growth. We will get 7-8% no matter what, because we have demographic benefits, we have many other things. Even if you completely mismanage the economy, something you will get. Right? But unless you invest in human capital, unless you allow markets to function, you will continue to drag the country's growth back. And my fear is not just this government, previous governments before that, that was kind of where they ended up with the economy. No, the first point you made about income inequality, you are absolutely right. It is enormous. And indeed, to give you another kind of more frightening statistic, is that even pre-COVID, if you ask the question, how many Indians are middle class by a global definition, not by a local definition, but globally, if we compare ourselves with France, Germany, etc., the same standard of middle class, $10 a day roughly is the income that is used as a cutoff to define middle class. Only 3% of Indians are above that cutoff line. So according to global standards, 97% of Indians are poor. Now it's a matter of how poor are they is the debate, but by global standards, a very small fraction of the country. And I would submit to you, therefore, growth is an essential aspect of what we need to do. And if we are going to grow, we are going to need to harness the capabilities of every last Indian. And which is why when I advocate for more investment in health or in education, it is not because I think they are poor people, so they need some handout and some welfare, but because I think we as a country need it if we are going to grow. Right? Otherwise, we're going to remain, both at this inequality as well as overall in aggregate low levels of growth. Right? So clearly, this is an important concern. Now, the other thing that you mentioned is what about insurance? Right? An important question. Clearly, people are spending a lot of money on healthcare, and part of the reason why you get 6% of Indians fall below the poverty line each year because of health expenses, and that's bad. But what is worse is that about double the number of Indians, 12%, are unable to get the healthcare that they need. So almost a fifth of our population is unable to get the healthcare that they need because of money concerns. Now, some of it is just income, but some of it has got to do with the manner in which it is spent, right? And that will take another conversation. I teach a course at the Indian School of Business on specifically this issue as to where will it come from. But one of the issues that let me leave to ponder with you on is that, we say private sector, right? And correctly, we point out that somewhere near 80% of all healthcare in India is provided by the private sector. It's entirely possible. Most of you, or many of you, will start your own hospitals, or join existing players in the private sector, because that's where the opportunities are, and that's where you can grow and do well, right? But if I now separate the private sector out between the corporate sector and the disaggregated private sector, and ask the question, what is the role of the corporate sector? Right? If I, for example, if I use the finance analogy, and I say that most financing comes from the private sector, and I say how much of it comes from money lenders versus how much of it comes from private banks, right? That's the distinction I want to make. The corporate sector, Fortis, Manipal, Medanta, Max, all of them put together provide only 4.5% of total healthcare. Bulk of healthcare is in the hands of the moneylender equivalents, the individual doctor, the small nursing home, the pharmacy. They are the ones providing bulk of the healthcare. In fact, Niti Aayog has a report that it published about 2 years ago, which shows 95% of healthcare providers have fewer than 5 employees in the country. Right? Now the question is, with such a disaggregated system, where are we going to go with thinking about insurance, thinking about care? The insurance companies, they have a market share of 7%. And sadly, their growth is just tracking Indian GDP. So their market share has remained 7% over the last 5 years. So how do we bring these separate pieces of the puzzle together to craft a solution is what I discuss in that course. Unfortunately, we don't have enough time for me to get into the depths of that. I don't want to start something in that area without concluding it. So I'm certainly happy to, maybe at some other time, have a deeper conversation on this, or if some of you are interested, I have the slides from that course that I'm happy to share with you. So Dr. Patel, we are nearly at time, and I can see that we are losing our audience rapidly. So maybe this is a good time to, thank you all for your time and your attention, and for the wonderful questions that I got. And thank you, Dr. Patel, for inviting me to speak here. I must say I was a bit trepidatious, but I did the best I could.
No, it was really wonderful. Thank you so much for taking out time for us. And I think this has really broadened our thinking. And we'll be thinking more from a broader perspective about healthcare rather than just the narrow perspective that we get in med school. So thank you so much.
Thank you very much, man. Thank you all for your patience. Bye-bye.
Bye. Thank you, sir.